So good evening and welcome to the 2024 NAMI New Hampshire Annual Conference, Cultivating Hope and Celebrating Everyday Heroes. Thank you for joining us. If you're new to NAMI New Hampshire, we are so glad you are here. If you're a longtime member of the NAMI New Hampshire family, thank you for coming back. NAMI New Hampshire is a grassroots organization that provides support, education, and advocacy to individuals and their families impacted by mental illness and suicide in the Granite State. We do this by offering a variety of programs and events, including today's conference. My name's Michelle Watson, and I'll be one of your co-hosts for the conference, along with my coworker, Karen Privé. If you have any technical difficulties, please reach out to Emily on the number on the screen. All conference presentations are in Zoom webinar, and this is a new platform for us. This is Zoom events, so this is part of the little difficulties tonight. There will not be an option to turn on your camera or your microphones, and you may have noticed we've also turned off the chat feature because that sometimes becomes pretty distracting. We do have, however, welcome questions in the Q&A, and we'll do our best to get to all of them. We'd like to express our thanks to our generous and supportive sponsors who help make today's conference available free of charge. For those of you who are here tonight and stuck with us so far, we will be entering you automatically into a drawing for one of Dr. Amador's books. You have your choice of one of his books, and the winner will be notified later this week. So now I'd like to introduce NAMI New Hampshire's Executive Director, Susan Stearns, who will get things started for us this evening. Susan?
Thank you, Michelle. Welcome, everyone. It's truly my pleasure to be here with you this evening as we kick off our annual conference. And it's my pleasure to have the opportunity to introduce tonight's keynote presentation. Our speaker this evening is Dr. Javier Amador. He is an internationally renowned clinical psychologist, author, and leader in his field. His books, published clinical research, worldwide speaking tours, and extensive work in schizophrenia, bipolar, and other disorders have been translated into 30 languages. He is also the CEO of the Henry Amador Center on Anosognosia and the founder of the Leap Institute. Dr. Amador is a visiting professor of psychology at the State University of New York, and over the course of 2 decades, he has served as professor of psychiatry and clinical psychology at Columbia University and director of psychology at the New York State Psychiatric Institute. His expertise has been called upon by government, industry, and the broadcast and print media, where he has appeared as a frequent expert for CNN, ABC News, NBC's The Today Show, Fox News Channel, CBS 60 Minutes, The New York Times, Washington Post, USA Today, Cosmo, Wall Street Journal, and many other national and international news outlets. Like many of us, Dr. Amador is also a family caregiver, caring for 2 close relatives living with serious mental illness. It is truly my pleasure to welcome you here today to our annual conference, Dr. Amador.
Thank you, Susan. I'm very glad to be here. And thank you, everybody. I'm sorry we're starting a little bit late, but we had some technical difficulties. I really wish I was there in person. I love New Hampshire and I love NAMI. NAMI is my second family. I've been a member of NAMI for 35 years, I think. 36 years. So we have a lot in common, I am sure. So where I'm going to start is really where the title of my talk brings us, which is the statement, "I'm not sick, I don't need help," which I've heard from family members suffering from serious mental illness, and I've heard from really countless patients I've worked with over the years. I'm a clinical psychologist, conducted a lot of research. I still do clinical work with individuals suffering from serious mental illnesses, and also with their families, as well as with healthcare professionals. But the focus here is to give you a sense of the problem when somebody with schizophrenia or bipolar or related disorder says, I don't need your help. There's nothing wrong with me. Leave me alone. So I want to really focus primarily this evening on what the nature of that problem is. What is causing it, and then give you a preview of how we best can engage and help people. The way I'm going to do that is to bring you to the beginning of the story, which is where I started in terms of encountering this problem. This is a picture of my brother Henry and me. I'm the little guy behind the car, pretending to drive. And Henry, 8 years older than me, is looking through the window. And I don't know if you can see the smiles on our faces, but they're not just for the camera. We really loved being with each other. We had immigrated from Cuba. We landed penniless, fatherless. Our father was lost in the revolution. And Henry was much more than an older brother. He was my best friend. He was a father figure even. So I want you to imagine in your mind's eye, 20 years after this picture was taken, and I was a 21-year-old college student living in New York, and Henry was 29 years old and living with our mother and our stepfather. My mother remarried a wonderful, wonderful man who we called Dad. Henry calls me in New York, where I was attending college, studying to get an undergraduate degree in psychology. And I picked up the phone, and Henry from Arizona, from our parents' house, said, "Come home quick. I killed Dad," and hung up the phone. I didn't think for a moment he had hurt our father, much less killed him. But it took me about an hour to get him back on the phone. And what became readily apparent to me was that he was suffering from psychosis. He had the delusion that he was playing the guitar and that his guitar playing had killed our father. It was this very bizarre delusion. He was hearing voices. He was hearing the voices of the devil. He had other delusional ideas about our mother abusing him, which were things that had never happened. I flew home, and in our blended family,
Excuse me, Dr.
Yes.
Amador? I thought it was just me, but I just got a text from somebody who said they couldn't see your slides.
Oh, goodness. I'm sharing the screen. Let's see. Let me try again. Share screen. Share that screen. And start the slideshow from the start. Can you see the slide?
I don't see it. Does anybody else on the panel see it?
No, I'm afraid not.
How about now?
There we
Yes.
go.
Oh, fantastic.
Yay.
Thank you for stopping me. My goodness, we've had our share of technical difficulties tonight.
It's good to be, we got them all over at the beginning.
All right. Well, I'm caught up on the slides. You didn't miss much. You just
Okay.
missed the title slide. So this is Henry and me, the picture I was showing you earlier, trying to show you. So I rush home to Arizona, and Henry's in his bedroom, holed up, feeling really depressed and suicidal because he was convinced, because of his delusion, that he killed our father. And I was in the living room with my brothers and step brothers and sisters. And one by one, they pointed at me and said, "You go help Henry. You go deal with Henry," is the word they used, actually, because you're the psychologist, which was absurd. I was 21. I was an undergraduate. I think the reason they selected me was because really what this picture that you're looking at represents, we were very close. We were quite literally each other's best friends, even though there was this 8-year age difference. So I went and I talked to Henry, and I said to him, a lot of the things I'm saying to all of you, you're hearing voices, you've got these ideas that just aren't true. You didn't kill Dad. Mom didn't abuse you. Tried to get him to get help. I tried for a week to get him to go to the hospital. I tried all kinds of things, including Mom's been through so much. She lost our birth father. She lost our stepfather, now Dad. Do it for her, do it for me. He just didn't want to go. I eventually called the police because he was talking about suicide because of his delusion that he had killed our father, our stepdad. The police ended up being great. I met him out front, explained the situation. They were really kind and compassionate. He gets to the hospital, he gets antipsychotic medication. And from my perspective and our whole family, he got well. The voices disappeared, the delusions disappeared. It was fantastic. Now, this was way back in 1981. So we had longer hospitalizations than we get today. At the end of that 1-month hospitalization, he's sitting at the table with his psychiatrist and his nurse and social worker and me. I was the family representative. And it was explained to Henry and me that he had schizophrenia and needed to take the antipsychotic medication for the rest of his life. He said, I understand. I can do that. Don't worry. So everything's good, right? We go home. Mom makes dinner. Henry retreats into his bedroom. He's alone in there. And I'm doing the dishes, and I go to throw something out in the trash bin under the sink. And what do you think I found there? I bet most of you know. I found that bottle of antipsychotic medication, which had so wonderfully brought him back to us. So I went and I took the bottle out of the trash, and brandishing the bottle, I went and knocked on his door and opened his bedroom door and said, "What the heck are you doing? You said you would take this medication. You needed it. You have schizophrenia." And he said, "I don't have schizophrenia. There's nothing wrong with me. I needed it back then, but I don't now." I said, "Henry, back then was 5 hours ago." And he said, "Well, I'm better now. I don't need it." That started a 5-year period where our relationship went to hell in a handbasket, because I kept telling him he was ill. I kept telling him he needed to take these pills. And he kept saying there was nothing wrong with him. This picture represents what our relationship looked like. Henry running away from me, running away from other family members, running away from mental health care professionals that wanted to help him, at times running away from police. During the 7-year period, he was in the hospital about 4 times a year on average, usually involuntarily. He dropped out of school, couldn't work, didn't have friends or a girlfriend that he desperately wanted to have a girlfriend again. He didn't. He was homeless for a while. Now, during the same 7-year period, I was in training to become a clinical psychologist. And I was on my internship year, the very last year of my training before my doctorate. And I was working on an inpatient psychiatric unit. And there was this woman just like my brother, saying all the same things I'd heard 7 years before. And during the 7 years, I was trying to convince him he was ill, and frankly, arguing with him often. All the same things. I don't need your help. I don't belong in the hospital, et cetera. I was very frustrated after my first interview with her, and I went and talked with my supervisor because I was in training. And as I'm telling him the same story I'm telling you, he puts his hands up and says, "Javier, stop talking." So I stopped talking. He says, "You don't understand. I don't mean you should stop talking right now. I mean, stop talking to her. Start listening to her. Ask her what she wants. Ask her what her goals are. Ask her what she thinks the problems are, not what we think. We think she's got schizophrenia. We think, her problem is she needs to take medication. She doesn't think those things. Go find out what she wants." So I went back out and I talked to her, and everything turned around. First question I asked her was, "What do you want?" And the first thing she said, and you're not going to be surprised by this, is, "I want to get the hell out of the hospital." And I said, "Well, I think I can work with you. I can help you to get out. It will involve taking medication." She said, "Well, I don't need the medication." And rather than argue with her, I said, "Well, I can understand what you're saying. You don't need the medication, but you do want to get out of the hospital, and that is one way we can get you out." We ended up partnering on that. So she agreed to take the medication, not because she had an illness, but because she wanted to get out of the hospital. And a light bulb went off in my head, really, literally. I had an epiphany that I had been doing things wrong with my brother for 7 years. Again, that this picture depicts. And I called him up. I was in New York still. He was in Arizona still, living with mom. And I got him on the phone and I said, "Henry, I'm sorry for all the times I told you you were mentally ill. I'll never do it again." I kept that promise. I never again told my brother he had a mental illness. Then I said, "I'm sorry for all the times I told you you needed to take medication, and I'll never do that again." I kept that promise. Within 6 months of this change in me, not in him, my switching from trying to convince him and educate him to listening and working with his goals, we were able to negotiate a deal where he would accept a long-acting injectable medication. He stayed on an antipsychotic medication given by injection once a month for the rest of his life. He died tragically, being a good Samaritan, actually, in a car accident. It wasn't his fault. But for those 18 years after this change in the way I talked to him, he stayed in treatment. He got 2 volunteer jobs. He had a girlfriend. He went to a clubhouse where he would, as he put it, spend time with those really nice mentally ill people. He never saw himself as somebody who was mentally ill. And importantly, at least it was very important to me, we got our relationship back. That's a picture of Henry and me, and you can tell by the way we're holding each other and smiling at each other that the trust and the love was back. That's me on the left with the Jerry Seinfeld haircut, and that's Henry on the right. So we got our friendship back, our relationship back, our family was healed, and he got into recovery. I asked him in the last year of his life, I happened to have this conversation I'm going to share with you. I asked him, Henry, do you think you have schizophrenia? And he laughed and said, no, I don't have schizophrenia. Because remember, I told him I'd stop telling him he had schizophrenia. So maybe he forgot that I thought he did. I don't know. He says, no, I don't have schizophrenia. And then I asked the $1 million question. I said, well, why are you taking these injections every month? It's antipsychotic medication. Why are you doing that? And he said, well, I do it for you and for mom and pops. Mom and pops were Betty and James. They ran the halfway house, is what we called it back then, that he lived in, the supported living arrangement. So what was my brother's answer? He was on medication for almost 20 years, not because he thought he had a problem, not because he thought he had mental illness. He was on medication for relationships, for 3 important relationships in his life. And that's going to be the theme of the solution I'm going to be introducing you to. But before I do, let's talk about how the media covers people like my brother. Too often we hear stories of crimes rather than stories of recovery. And here's one such story. This is a picture of Margaret Mary Ray and her children. You probably don't remember who Margaret Mary Ray, but many of you will remember her as David Letterman's stalker. She was criminalized. She was arrested repeatedly because she would show up in the celebrity late night talk show host's house because she had a delusion that she was married to him. She was absolutely certain that David Letterman was her husband. Just no matter how many times the police picked her up, no matter how many times she was convicted of violating restraining orders, criminal trespassing, she never understood. She never came to believe that she had never been married to David Letterman. She ultimately died from her illness. And what I'm referring to is suicide. The suicide rate in people with disorders like Margaret Mary had, she had schizoaffective disorder, but also in schizophrenia and bipolar disorder, runs about 10%. The mortality rate is higher than most forms of cancer. We're talking one out of 10 people will die from suicide. One of the biggest predictors, not being in treatment. So being in treatment has personally and professionally been such an important goal in my work and in my life. So I have a question for all of you. Denial of illness impairs common sense judgment about the need for treatment and the services surrounding treatment. Would you agree with that? Since I can't see you, I am, though, going to ask you to raise your hand and look around the room. Do most people agree, most of you, that if you're in denial of having an illness, it's going to impair your judgment about the need for treatment? Okay. I don't agree. If I take my brother's perspective, if I take Margaret Mary's perspective, the story I just told you, roughly 6 million Americans with serious mental illnesses, with the schizophrenia spectrum illnesses, so bipolar, schizoaffective, delusional disorder, schizophrenia, those are the disorders I'm focusing on. If I take their perspective, it's common sense to refuse treatment. Doesn't make sense to take treatment. Let me bring this point home a little bit further. Raise your hand if you inject yourself with insulin, knowing for certain you do not have diabetes. Raise your hand and look around the room, see if anybody's raising their hands. Even though I unfortunately can't see you, I know that there's probably no one raising their hands. Why wouldn't you inject yourself with insulin? It could hurt you, it could even kill you. And most important, you don't need it. That's what we're up against. But are we dealing with denial? In most cases, I'm going to show you some research in just a moment, we're dealing with a symptom called anosognosia. It's a neurocognitive symptom. It's a symptom of these brain disorders. Anosognosia was first described in 1919 by the neurologist Babinski. He's the same neurologist that discovered the Babinski reflex in newborn infants. In anosognosia, what he described were people who had neurological damage to the brain. for example, resulting in paralysis on one side of the body, hemiparesis it's called. And yet they were completely unaware that they were paralyzed. I did a year-long neurology rotation in my training years, and I evaluated people like this. And I'll never forget this one man who I knew was paralyzed on one side of his body. And I was evaluating whether he was aware of it or not. And I asked him, "Can you move your arm?" He said, "Yeah, no problem." I asked him to move his arm. It didn't move. And I said, "Why didn't you move your arm?" He got a little upset with me. He said, "I did move my arm." I said, "Well, you weren't looking. Look at your arm with me and move it again." He can't move it. So now I'm educating him, aren't I? I'm showing him he's got a problem with movement in his arm. He's got a paralysis. Instead of learning that, he got angry, paranoid, and accused me of putting something in the IV in his other arm to paralyze his arm. So he did not understand, he did not see it, and then he confabulated. I'm going to talk just a little bit more about that in just a moment. If you come away from this talk that I'm giving convinced that what you're seeing in your loved ones, or if you're a professional, what you're seeing in your patients or clients is anosognosia, it is really helpful to be able to pronounce it. So this is a trick that I use. A woman named Anne knows egg, and she's nosy, nausea, anosognosia. On the count of 3, would you all say it together? 1, 2, 3. Anosognosia. I hope you did it, because it's really worth learning how to pronounce this if you want to talk about what I'm going to be talking about and what I hope you'll learn today. So let me give you an example of anosognosia in a neurological patient. This is a study I did with my colleagues at Hillside Hospital in Queens, New York, and we looked at neurological patients. So I'm not talking about mental illness right now. And we looked at people with lesions in the frontal lobes of the brain, damage to the frontal lobes. Why were we interested in that? Because the classic descriptions in neurology did not include the frontal lobes producing anosognosia. But we thought frontal lobes might be involved because we see frontal lobe dysfunction in serious mental illness. So here's the task. We asked this man, "Can you draw this clock?" A scale of 1 to 7. 7 is a perfect copy, 1 is a terrible copy. How do you think he'll do? This is part of a standard neuropsychological test battery. He looks at the clock and he says, 7. I'll have no problem. I can do it, right? Most of you would say 6 or 7 and indicate the right time. No problem. This is what he drew. Did he have a problem? Yeah, obviously, but it wasn't obvious to him. I asked him on that same scale of 1 to 7, how did you do? And he said 7. He did a perfect copy. So even when faced with what I think is irrefutable evidence that he's got a neurological symptom here, it's called a construction apraxia. Even when he's faced with that proof, he didn't learn that he had this neurological symptom. So I pointed to the 12 inside that rough circle. I asked him what number that was. He said 12. And then I started pointing to the 4 12s outside, and one after another. I asked him what number, and he says 12, 12, 12. You'd think he might learn at that point that he has a problem. Instead, he got very flustered, angry, and pushed the paper away and said, "That's not my drawing. What are you doing?" He became fearful, if not paranoid. Thought that I'd switched the drawing on him. What is that? That's a confabulation. What's a confabulation? Our brain is basically making up stories to fill in gaps in our memories and perceptions. So he knew he could draw that clock, right? That's what he remembered about himself. That's his perception of what he could do. But when he was faced with this drawing, he confabulated and said, "It must not be my drawing." And I saw this in my brother. I've seen this in many people, many patients I've worked with over the years. When asked, for example, "Why are you in the hospital?" And they give me all kinds of ideas that make no sense. They're confabulations. So I said I would talk about some research that will hopefully help you understand the nature of anosognosia in these disorders, these psychiatric disorders. And I'll just start with where I started in my career. In 1990, my colleagues and I at Columbia University in New York published a review of the literature looking at the research that had been done. And basically, there was only about a dozen studies. Today, there are over 300 studies of this problem. So we've learned a tremendous amount. I'm going to give you some of the high notes, some of the headlines. But one of the things that we did after we reviewed the literature is we made a proposal to the field, to our scientific colleagues. Hey, when we see frontal lobe dysfunction in schizophrenia, bipolar, schizoaffective disorder, maybe these are the same people who don't have awareness, who we typically say are in denial, but maybe they're actually people who are having unawareness because of frontal lobe dysfunction. Well, colleagues from around the world immediately tested this hypothesis, and all of these studies listed here. And if I listed all the studies in the literature, I'd have 4 more slides. So I'm not going to do that. But these were the early studies from 93 to 2004, finding strong, moderate to strong correlations between executive or frontal lobe dysfunction and poor insight, not understanding that they have mental illness. So this is evidence of how the brain is working, how it's functioning. And when there's hypofrontality, the frontal lobes are not functioning up the speed, up the par. These are the same people who tend to say, I'm not sick, I don't need help, and you can't convince them and you can't educate them. Now that's how the brain is functioning, how it's working. What about how the brain looks? Does the brain look different in people who have insight compared to those who don't? Well, here's 20 studies that compared the brains of people with schizophrenia who had awareness, who would say, yes, I have schizophrenia, to compare them to people who, patients who said, I don't have a problem, like my brother. I don't have any mental health issues. I certainly don't have schizophrenia. All of these studies found significant differences between those two groups in one or more brain structures. The brain structures were almost overwhelmingly in the frontal cortex of the brain, just like we hypothesized, and the prefrontal cortex, also relevant to our theory, to our hypothesis. 3 of these studies included patients who had never been treated with medication. Now, why is this of interest to me? It shows that these brain differences did not result from medication. Medication wasn't causing things like, and this is among the findings, reduced gray matter in the frontal cortex or the prefrontal cortex, other kinds of brain differences in terms of how the frontal lobes look. The other thing is about these 3 studies is these were all first episode patients, very first psychotic episode. So these brain differences between patients who were aware compared to patients who did not have awareness that they had an illness were present from the very beginning, age 18, early 20s. The brain differences we're finding in terms of how the brain's functioning and how the brain looks are from the very beginning and continue throughout the course of the illness. So one more study. Back in 1990, my colleagues and I were asked to run a field trial. It was a big study all over the United States, 5 different sites, over 500 patients, and we were the New York Columbia University site. And we were able to put together an evaluation of awareness of mental illness. I'm just going to show you results from schizophrenia subjects in the study, but I'll just share with you that we saw very similar results in schizoaffective disorder patients and people with bipolar disorder who had psychotic symptoms. That's what we were particularly interested in. And by psychotic symptoms, I'm talking about like my brother had, hallucinations, hearing voices, seeing things that aren't there, for example, and delusions, like his delusion that he had killed our father. So psychotic disorder patients, I'm just going to show you the schizophrenia results. But again, I'm asking you to remember we found very similar results in the other patients who had psychosis. What we found is that 60% had serious problems with being aware that they had the diagnosis of schizophrenia or these other disorders. This finding has been replicated a couple hundred times now. Roughly 50 to 60% of people with these illnesses at any given time you ask them will tell you they don't have a mental illness. Only about 40% are generally aware that they have a diagnosis. So that's a finding that's been very well replicated. Another finding related to this is that people have looked at anosognosia over time, so over a 2-year period, and have found that even when successfully treated with medicines, that the anosognosia in most of the patients in these studies stayed poor. So just like my brother, 20 years on medication, hallucinations, delusions gone, treatment's working, the anosognosia was still there. Now that's not everybody. Some people do develop awareness, insight with treatment, but the majority don't. What does that suggest? It sounds like bad news, right? Well, actually, the good news is it tells me we've got to approach people with this symptom really differently. And I'm going to give you a bit of information on how different it is. You have a clue because you saw what I did with my brother. You heard what I did. That's a big part of how our communication and our approach to people with this problem needs to happen. But one more finding from the study, we were the first to look at awareness of symptoms. How aware were the subjects in our study of the symptoms they had? And we found all kinds of problems with illness awareness, unawareness of delusions, of disordered speech, thought disorder, the person's rambling, circumstantial, difficult to understand, unawareness that hallucinations were actually false perceptions. And then we have 3 negative symptoms listed here. Flat affect, that inability to express emotion, anhedonia, asociality. So what's the headline I want you to take away from this? On the left here, the pie chart, 50 to 60% of people at any given time with these illnesses don't know they have the illness. And then importantly, it's not just unawareness of a stigmatizing mental health condition. It's unawareness of the signs and symptoms that make up that diagnosis. So all kinds of problems with awareness. So many of you haven't heard of this before. And if any of you are in the field like I am, psychologists, psychiatrists, social workers, case managers, you might not have heard of this. And yet it's in our DSM, it's in our diagnostic manual that all of us professionals in the field use. So in the schizophrenia and other psychotic disorders section, well, let me just tell you, in the DSM-4, which was published 22 years before the book I'm going to tell you about right now, I was co-chair of that revision. And together with my co-chair, we put together a panel of experts and reviewed the literature. And what we ended up putting in the DSM-4, TR, for those of you who are in the field, is very similar to what you're going to see now in the DSM-5. The DSM-5 is stronger, though, when it comes to the question of whether we're encountering denial or stubbornness or someone just being difficult when they tell us they're not ill, or if we're encountering a neurocognitive symptom of the brain disorder called anosognosia. So here's what it says. Unawareness of illness is typically a symptom. It's not a coping strategy like denial. It is comparable to what we see in neurological deficits following all kinds of brain damage, termed anosognosia. It includes unawareness of symptoms that researcher just showed you, and may be present through the entire course of the illness. So that stability of anosognosia and how it's resistant to treatment, that I was just discussing a few moments ago. It's also common in schizoaffective disorder. We also know from other research, it's a different part of the DSM, that we see anosognosia in bipolar disorder with psychosis. During the manic episode, patients tend to be unaware that they have mental illness. During the depressive episode, that anosognosia seems to remit a bit along with the other manic symptoms. So it's a little bit different in bipolar disorder. It's more episodic, the anosognosia. And it predicts all kinds of negative outcomes. This symptom of anosognosia is the most common predictor of somebody who will refuse treatment or drop out of treatment. The most common predictor of non-adherence to treatment. It predicts all kinds of other negative outcomes, like higher relapse rates, like what was happening with my brother, more involuntary treatments, poor psychosocial functioning, so inability to work, form intimate relationships, go to school. It also results in aggression in many people. Not physical aggression, not violence, but people getting angry a lot. And that makes sense. If everyone around me thinks I've got schizophrenia and I know for certain I do not, I'm going to start getting upset. I'm going to start getting, pardon the expression, pissed off at my mom, my dad, my brother, uh, uh, friends and family, and the doctors, and maybe even the police officers or crisis team people who keep picking me up and telling me I need to get help. I'm going to start to get upset. This symptom is also a predictor of a poor course of illness measured in a wide range of ways. So let me shift gears and let me talk about treatment for a minute. What do you suppose the problem is with oral antipsychotic medications? I think the biggest problem with the medications you take by mouth, the oral medications, is that people either refuse to take them or they stop taking them without telling anyone. And that's what my brother did. Remember, he threw the medication in the garbage can. He didn't announce it. He didn't tell us. We just, got lucky and discovered it. Not that it changed much because I argued with him quite a bit after that instead of taking a different tact. But it's a big problem, and the research confirms my personal experience. This study, which is just representative of many studies that find almost identical results, this study found 50 to 75%, a half to 3/4 of the patients in their study didn't take medication at all or just took a little bit subtherapeutically. 50 to 75%. This is the standard finding, 50% at least. This study looked at people over time. Within 7 to 10 days of starting treatment with an antipsychotic medication, 25% of the patients, and these were schizophrenia, people with schizophrenia and schizoaffective disorder, 25% were non-compliant and stopped taking the medication after just 7 to 10 days. Half were off after only a year, and 75% were off after 2 years. So this is a huge problem. I know many of you in the room are personally dealing with this really frightening problem of having a loved one who has benefited from medication or might benefit from medication if they haven't been on it, but want nothing to do with it. When we're successful at offering treatment, and I'm going to get to that in just a few moments, long-acting treatments are indicated. That's my personal experience. That's what happened with my brother. He didn't miss an injection for 18 years. This study found that 50% of the patients who are on pills and tablets, on oral medication, stopped during the course of the study. They stopped taking the medication. Only 17% on the long-acting injections, which are well, I'll tell you how often they're given in just a moment. Only 17%. Flip those numbers around. 50% on the pills and capsules, stay on it. Only 50%. 83% on the long-acting injectables stayed on the medication. So these are not different medications. It's just they're given, the same medications given in different ways, by mouth or by injection. So why this big difference? Here's what I think. When I have anosognosia, if I have anosognosia, and I have to put a pill in my mouth once, maybe twice, or even 3 times a day, put pills in my mouth that represent everybody's opinion that I have a mental illness, I'm going to eventually get resistant and stop taking it. Whereas with long-acting injectables, it's a social interaction. I'm not alone in the bathroom taking a pill or flushing a pill down the toilet. I'm going to an appointment. I'm meeting with the receptionist that maybe I have a good relationship with. I'm meeting with the nurse or the PA who's going to give me the injection. And I only am doing that 12 times a year or 4 times a year. So these injections are given, many of them once a month, and there's one, and there'll soon be more than one, given only once every 3 months. So I think that's why we get this superior adherence, compliance with medication when it's a long-acting injectable. Common sense reasons, I think, are that we see this difference is that with long-acting injectables, it's a smoke detector. We know when someone is stopped taking the medication. We don't have to look under a mattress, in a toilet, or in the trash can for a pill bottle. We know because they've missed the appointment. It also reduces tension. I don't ever have to ask someone, whether it's my brother, whether it's a loved one or a patient of mine, I don't have to ask them, are you taking the medication? and put them in a position, if they're not taking it, of maybe wanting to lie to me and say they're taking it when they're not. Because I know they're on the medication, or if they miss the appointment, I know they're not on the medication. And when they're not on the medication, when they miss an appointment, I can use my relationship and approaches like the LEAP approach I'm going to introduce you to discuss that person's reluctance to keep their appointment. I'm going to give you a website, and then at the end and at the website, we have free videos. And one of them is actually a phone call from a doctor to his patient who has just missed an appointment for a long-acting injectable. And he's using the LEAP approach to help this person decide to make a new appointment. So there's other videos as well that I'll introduce to you there. So awareness of illness and acceptance of treatment. Well, awareness of being ill is the top predictor. What do you suppose the other top predictor is? If you look at the literature on therapeutic alliance with professionals and their clients, it turns out it's a relationship, but this is also true of family members and friends. It's a relationship that involves you listening to the person without judging them and respecting their point of view. Very active listening. So for example, somebody says to me, I don't have bipolar disorder, and my problem is, I just need to get to Washington and join the president's cabinet because the person maybe has a grandiose delusion. Well, if I'm going to respect and not be judgmental, I need to actively listen and say something like this. So what I hear you saying is that the president needs you and you need to go to Washington. Did I hear that right? Right. And the person is probably going to say, yeah, you heard me. Now they may think I believe what they believe. That LEAP approach and the kind of relationship you're trying to build here that leads to acceptance of treatment is never dishonest. You never pretend you believe a delusion, but there are tools to deal with somebody maybe misunderstanding and thinking that you believe them when you don't. And I'll be introducing you to those in just a few minutes. But non-judgmental, respectful communication, and the person I'm talking to knows I'd like to see them try some treatment, right? Try treatment, not you need treatment. As soon as I say you need treatment, I'm getting into a I'm right, you're wrong argument with the person where I'm saying I'm right, you need medication, you're mentally ill. And they're saying, no, you're wrong, right? So words like, I like you to try it, I like you to give this a chance, rather than I think you really need this, is usually the approach that is part of the constellation of communication strategies that help people accept treatment, even when they have anosognosia, even when they don't understand they have mental illness. So let me summarize what I just talked about, which is a review of the Therapeutic Alliance literature, just the summary of it. So what do we know about anosognosia and acceptance of treatment? We don't win on the strength of our argument, trying to prove to the person, give them the evidence that they have mental illness. We don't win on that. We win on the strength of our relationship, the non-judgmental, respectful relationship. And the person knows we'd like them to give treatment a chance. So to summarize, anosognosia, typically called poor insight, sometimes it's called denial, into having a serious mental illness is a symptom of the brain disorder. It's a neurocognitive symptom. It's not denial. It tends to be stable over time in most people, not everybody, and tends to not improve with treatment. It is the top predictor of who doesn't want treatment and who drops out. And it predicts all kinds of negative outcomes, like hospitalizations, involuntary hospitalizations, poor psychosocial functioning. And it's just a barrier to helping people, to creating an alliance with the person, working together. So when we talk about anosognosia, how we talk about it really makes a difference in how we think about it. So I would encourage you to not say things like, he does not accept he has an illness. She refuses to acknowledge she has schizophrenia. Would you ever say that somebody refuses to stop hallucinating? No, because you know it's not under their control. Same thing with this awareness. Nobody's refusing to acknowledge. Nobody's denying. Nobody's failing to admit, like they really know, but they just won't admit it. Won't admit, again, like they really do know they have schizoaffective disorder, but they just won't admit it. or refuses to admit. How can we talk about it? Say things like, she cannot comprehend she has an illness. She's intelligent, she's bright, but she can't comprehend this thing. He's unaware that he has mental illness, unable to see or understand that the person has mental illness. And ideally, you'd say has anosognosia for mental illness. So I've been talking a lot about this problem and how it predicts whether somebody will accept treatment or not. But let me give you a sense of how it feels to have this. And I need a volunteer, preferably somebody who's married, but not necessarily, and currently working. Did I forget if we pre-selected someone or if somebody's going to volunteer randomly? Michelle.
It's me.
Okay, are you my volunteer?
I am, and I'm looking kind of dark on the screen here.
Well, maybe you want to be incognito. I don't know. There you are. Now, Michelle, I forget, do you have a partner?
I do not. I am single.
Okay, and do you have children though?
I do 3 beautiful grown children and a grandchild.
Okay, so 3 children and a grandchild.
Yeah.
And how old are they? How old do you believe they are?
35, 33, 29, and a 2-year-old grandson.
Okay. And what's the first name of your supervisor at work?
That's Liz.
Liz. Okay, Liz. Michelle, this is really awkward, and I want to apologize to you and to everybody attending and watching us. I need to take a few minutes out, folks. Liz actually contacted me and asked me to help you with something. It turns out that those 3 children, the 35, 33, 29-year-old and the 2-year-old grandchild, do exist, but they're not your children and it's not your grandchild. Their parents, John and Susan, have been really concerned because I understand you even tried to pick the grandchild up to babysit. You've been contacting their children, their adult children, and there are restraining orders that I could email to you that indicate that you're not only not their parent, and this little, is it a little boy or a little girl? I forget.
Little boy.
You're not this little boy's grandmother. Would that convince you if I sent you? No, of course not, right?
Mm-mm.
Well, look, the good news is we've been able to, well, here's some bad news. Liz has put you on a medical leave of absence. It's not really bad news because she cares deeply about you, but she can't afford, for the organization to have somebody who's being arrested for stalking this family. Okay. I know this sounds funny to you, but it's a really serious problem. And the good news is that she wants you to come back to work. She wants you to get evaluated and treated. And if she can get a letter from a treating clinician that you're accepting medication, that these delusions have resolved, you can come back to work. She's also arranged, with my help, for a crisis team to meet you out front. Would you be willing to go and talk to them?
I shouldn't have to talk with them because I don't need help. I'm perfectly fine and capable of doing my job.
Okay, well, you don't have to talk to them. You're not a danger to self or other. That's the report I got. You're not threatening to hurt anybody or hurt yourself. So you certainly don't have to talk with them. Can I ask you a question?
Sure.
When the conference is over, where do you go?
I'm home.
Okay.
Yeah,
And do you live there by yourself?
I do.
Yeah. And do you ever have this little boy over that you think is your grandson?
Yeah, and I'm babysitting him on Thursday.
Yeah, well, that's got to stop. And we've heard that there's actually been charges of abduction, of kidnapping. Do you contact the 3 children you believe you have?
Of
Yeah.
course, I was contacting them yesterday.
Yeah. And as a result, they were going to call the police, but working together with Liz and me, they decided to hold off. So you go home after this conference. Are you going to call any of them?
Yeah, because I need to verify. Maybe somebody said something to them.
Okay.
This
And guess
doesn't make
what?
any sense.
Okay. It doesn't make sense to you. It makes sense to the rest of us. So what's going to happen when you contact one of them, your son, the man you believe is your son? is you get arrested. The police show up and they take you into custody and you're brought before a judge. And I'm the judge right now. Ms. Wagner, I'm sorry to see you here. I have here on the bench a number of restraining orders. I see a charge of a violation of a restraining order, being in communication with somebody that you're not supposed to be in communication with. Now I got a choice for you. We can arraign you and you can go to trial, or we have a pre-trial mental health diversion program. If you agree to go get treatment, and I understand your supervisor at work, her name is Liz, wants the same thing. You go and you get treatment, and I get positive reports over the next 6 months, we can dismiss all these charges. So what do you want to do? You want to go to trial or to the treatment we're offering?
I don't like either of those options because I haven't done anything wrong and I
I know,
need to
ma'am.
work.
I know, ma'am, but I'm the judge still. Ma'am, I have a full docket. You need to make a decision, treatment or trial.
I guess I'll do treatment.
Okay, so you're transported to a psych ER. The psychiatrist evaluates you and offers you an admission. She says to you, I'd like you to come upstairs. We understand you're having a lot of problems with law enforcement, and there's these restraining orders against you to keep you away from these three young people and this little boy. Would you be willing to go up to the psych unit? You're not a danger to yourself or other, ma'am. We can't hold you against your will.
You
No?
shouldn't. I don't want to.
Okay.
I want to go
That's your choice.
home.
All right, so we're going to sign you out against medical advice. We wish you the best of luck. That's what the psychiatrist says. You go out front. Do you call or text any of these three young adults you told us about?
Of course.
Guess what happens? What do you think happens? The police show up again. They pick you up because you have violated a restraining order. This goes on for a whole year. Every time you try to see the little boy you think is your grandson, or these three young adults who you believe are your children, every time you make any attempt to contact them or to see them, you're arrested, you're brought back into court. Maybe you get trial, maybe you get probation that requires mental health treatment. Do you think after a year of those experiences, you'd finally understand these are not your kids, that is not your grandson?
No.
What about 5 years? No. That's what it's like to have anosognosia, right? The belief is as rock solid as your truth, your belief. These are your three adult children, and this is your beautiful little grandson. You know that's true. No amount of evidence, no amount of consequences is going to change your mind. That's what anosognosia is like. Now, I have one more question before I let you go. Could I?
Yeah.
Any feelings as you imagine this happening to you? Did you have any feelings?
It's an awful feeling and it feels like a conspiracy. That's what it would feel like to me, is that people were conspiring and I would want to go to as many people as I could and talk with them to find out what was going on.
Okay. So it was awful and sounds like you thought it was a conspiracy, so you got kind of paranoid.
Mhm.
Did you imagine 5 years going by, and your little 2-year-old grandson is 7 years old and you've never seen him? How do you think you'd feel?
I feel like I've been ripped off, like something had been taken away from me, and just incredibly sad and angry and hurt.
Sad and angry and hurt and ripped off. These are among the feelings I hear from people, thousands of people now that I've worked with who have anosognosia. They are by far some of the loneliest people I've ever met, because family, friends, doctors, crisis teams, law enforcement, everybody's telling them their truth is delusion, like I was doing in this role play.
Mm.
And for everybody, this was a role play. Michelle does have 3 children and a beautiful little grandson. And I hope you'll go give him a big hug and a kiss when you get home, or when you see him on Thursday.
I will,
All right.
sure.
All right. Thank you for helping all of us out. I really appreciate it.
Thank you, Dr.
You are
Onaga.
released, ma'am.
Thank
You're
you.
very welcome. Take care. So when we're trying to help someone, let's say Michelle really was somebody who had delusions. The case manager, the doctor, the parent, social worker, that we know best, we're the experts, we've got information she needs, like I was role playing. That doesn't work. There's no collaboration. She knows her truth, her reality. We think it's delusion. So we can't expect her to be grateful for the diagnosis, receptive, or adherent. Accept treatment, stay in treatment, go to treatment. It's irrational for me to expect that. What I can expect and should expect, look, I got some of the feelings. Michelle talked about feeling paranoid, sad, angry, hurt. Look at the feelings on the slide: frustration, anger, hostility, fear, suspicion, loneliness, depression, and isolation. These are the feelings that we see over and over again in people suffering from anosognosia. We can also expect the person to refuse treatment or pretend to be in treatment when they're not, be secretive about it. This is the nature of the problem. So how do we resolve it? I'm going to tie this up in the next 3 minutes, 5 minutes. The LEAP approach came out of a inpatient psychotherapy study that Aaron T. Beck, who's the father of cognitive psychology, that Dr. Beck and I received a grant for. And from that inpatient program, I pulled out 7 tools, which I'm going to review in just a moment. The LEAP approach was selected by SAMHSA for their family toolkit, and it's focused on developing relationships that result in acceptance of treatment and the services surrounding treatment. So here's an overview of the tools. You reflect back without judgment, reactions, or contradictions. So if Michelle tells me her story, let's say I'm her probation officer because she keeps getting arrested, and she tells me her story, I'd reflect it back. So Michelle, what you're telling me is when you went to that NAMI New Hampshire conference, that doctor took away your whole family. Is that right? Did I understand that correctly? Yes, she would almost certainly say, right? Then I express empathy. You told me it made you feel really sad and angry and hurt. Did I get that right? And she's going to probably say yes. And then I'll normalize the feeling by saying, I'd feel the same way. Now, she might think I agree with her. I'm going to show you how to deal with that in just a moment. We focus on areas where we can agree. I abandon my goal of trying to convince her that she's got an illness. So we could agree on staying out of jail, getting her job back, convincing Liz that she can come back to work. We can agree on her not getting arrested anymore. And we partner on those goals that we can agree on, right? Not argue about whether or not she has 3 kids and a grandson. I delay giving hurtful and contrary opinions. So as I'm listening and empathizing, she may say, so do you believe that these are my kids and that's my grandson? I might try to delay if I can. Here's how it would sound like. Michelle, I promise I'm going to answer your question about the 3 kids you're telling me about and the grandson. Before I do, can you tell me more about how you ended up working with me in this clinic? Would that be okay? Can you tell me more? So it's just a request, really you're asking permission to hold off on answering the question. Now, if she says, no, I want to know, we give our opinion with humility and in a way that respects the person's perspective. In the LEAP approach, we call it the 3 A's. We apologize. We acknowledge our fallibility. We ask the person to agree to disagree. So if she asked me, do you believe these are my kids, Dr. Amador? I'd say, you've asked me several times. I've been delaying. Thank you for letting me delay. I'm sorry. That's the apology. I could be wrong. That's acknowledging my fallibility. And I guess I don't see that they are your kids. And I am really sorry, and I hope we don't have to argue about it. That's an example of how you give your opinion with the LEAP approach. And then we apologize for acts and interactions that felt hurtful, disrespectful, or frustrating. This is just like learning a new language. You can go to our website and look at free videos and practice with each other, role play difficult conversations that you're anticipating having with a loved one, or if you're a professional with a client. I'm going to end on general guidelines. You absorb what you've heard by active reflective listening. You emotionally connect through empathy and apologies when you've been hurtful to the person. And then you can problem solve. But first, you kind of really absorb and emotionally connect before you can find areas of agree and partner on them. You use each of these tools as you need them. It's not like you listen first, then you empathize, then you agree, then you partner. It sounds like steps, but really there's 7 tools in a tool belt. You may start with giving your opinion in that humble way I described. If I'm working with Michelle, I may start right off with an opinion. She asks me, well, before we start, Dr. Amador, I want to know if you believe me. well, I'm really sorry, and I could be wrong. I guess I don't, it's not that I don't believe you, it's just I don't see the same thing you see about these three adults and this little boy. I wish I did see it the same way because I don't want to argue with you. So I might lead with my opinion. You use each of the tools as you need them. So thank you for bearing with us for the delay and for allowing me to go a little bit longer. If you have a phone, you can just take a picture or hold your camera up to that square, that QR code. That'll take you right to leapinstitute.org, or you can type it out. Why am I telling you about that? We're not selling anything there. There's a resources tab and free videos. So there's a video I told you about already. There's another video where a young woman finds medication in the garbage can and goes and talks to her husband about it. We show her using the usual approach, and then we show her using the LEAP approach. There's another video offering long-acting injectable medication. So there's a number of different videos. There's a TEDx talk that I gave that we've gotten a lot of feedback. It's gotten close to 1 million views, and we got a lot of feedback that's really helped people understand and develop empathy and compassion for their patients or their loved ones. So again, thank you so much for sticking with us. And again, I apologize for going a little bit late. Thank you.
Thank you so much, Dr. Amador. You know, I saw you present at NAMI Vermont this fall and go through that role play, and it's just as emotional, if not even more this time, because, you know, not only is Michelle a coworker, she's a good friend. Liz is also my supervisor, and it's, you know, it really puts you in that person's position to empathize with somebody that's
That was
dealing
my
with it.
goal. That was
Well,
my
it
goal.
was effective.
No, that we have the experience. I mean, it's so lonely when you have anosognosia. It's really a lonely place to be. So thank you for the feedback. I appreciate it.
So we do have a few questions coming in right now, and I didn't get a chance to ask you if you want me to read them to you, if you want to go through them. What's the best process for you?
Why don't you read them to me? That'd be okay.
Okay. So how do you approach those who are moderately aware of their diagnosis, and how to identify them?
If they're moderately aware, I would still kind of refrain from trying to educate them about the symptoms or the parts of their illness they don't understand. Because if they don't understand it, then why try and educate? Instead, really focus on listening and understanding what they do know. And frankly, the LEAP approach is more about behavior, influencing behavior, not influencing attitudes. So really listening, being empathic, and trying to see if the person can agree with you that treatment is useful to them or is worth a try. And that's what you work on together. That's what you partner on together. So rather than educating, listen and empathize and find a path forward together. That makes sense.
Thank you. Let's see. Would it be inappropriate to offer therapy resources for someone who is having these experiences to deal with their emotional toll of people not validating their experience?
I offer therapy all the time. I highly recommend it. You know, again, these are people who are often traumatized and lonely and sad. And if you imagine that really happened to Michelle, she talked about feeling paranoid and awful and angry, hurt. What better reason to see a therapist than to get somebody to help you with all those feelings? And then there's also cognitive therapy for psychosis. So even without medication, you can work on those symptoms of hearing voices or having delusions through talking therapy, through psychotherapy.
Great, thank you. Oops. Why do you think so many mental health professionals are unaware of this condition?
Because there's great question. There's two reasons. There's a natural gap between science and practice. Research gets published in journals. All us science nerds read it, and we publish and we talk to each other and we write grants. And it just, there's a gap between that science filtering down. That's one reason, unless it's drug companies, because then there's multi-billion-dollar industry And, and I think it's fantastic. They have the resources to educate. So that gap is much smaller when there's advances in drug treatments. But, for behavioral treatments and things like anosognosia, that research kind of gets stranded in the journals. So that's one of the reasons. The other reason is people just intuitively think the person must be in denial if they don't think they have an illness. And so there's a rush to judgment, and then we close off our mind to it. So I think those are the two reasons: a gap between research and practice, and a rush to judgment that this is denial.
So, I see a number of people raise their hands. If you could put your question in the Q&A, that would be very helpful. Thank you. Let's see next. It would be a good gateway to therapy without focusing on the delusions. I guess that's a statement.
Yeah. Yeah, absolutely. It's a way to engage people in therapy. Yeah.
Has it ever been your experience that folks become aware of their illness at some point?
Absolutely. Absolutely. There's a couple of caveats. One is just generally about 15% of people do develop awareness. So anosognosia tends to be pretty kind of semi-permanent in most people, but about 15% do. And then there's another set of research findings that long-term stable treatment with a long-acting injectable is associated with increased awareness, increased insight. And then there's only 2 studies I'm aware of, so that we really need more, but that Clozaril has been associated with an increase in a remission of anosognosia, and increase in awareness. So some people naturally do develop awareness with treatment, but only a minority. And then long-acting therapies, long-acting injectable therapies for 2 years or longer is associated with increased awareness. And then there's at least one oral medication, Clozaril, that we think its early findings may increase insight.
Great, thank you. Let's see. Do you have suggestions on how to combat the loneliness my family member living with anosognosia has?
Yeah, talk and listen. Talk and listen. And be curious and ask questions. And if the person doesn't talk much, but they're a texter, I can't believe I'm saying this because when my kids were teenagers, I used to hate all the texting, but send them a text. Do you want to come out for dinner if you're living in the same house? Miss you. I guess I would need to know more about the situation, but there are a number of different things you could try. Also, taking the person out for a walk. Would you help me with the groceries? Just engaging the person, not letting them stay alone in their room all the time, lonely.
It's also lonely for the family members too.
It is. We can burn out. We need support. Go to NAMI support groups.
Yes.
I did. It helped me a lot.
We know we have a lot of support group leaders on tonight, as well as participants. One of the meetings was supposed to happen tonight, and they canceled the meeting, so the participants could join us live tonight. Do you have any trials with folks who have bipolar? I'm really struggling. My whole family's struggling to support my sister. The strategies seem very practical, though.
Yeah, no, we've studied the LEAP approach with people with bipolar disorder, and it's very relevant and very helpful, generally, obviously not always. And look, what person doesn't want to feel heard and understood and empathized with? And the thing is, when I feel listened to and empathized with, and I feel understood, I'm now going to become more interested in your opinions. There's an ancient Roman poet who said, "We are interested in others only when they are first interested in us." So, yeah.
And so this one kind of leads a little bit into that. And this is a statement, but maybe some suggestions that you might have. My adult daughter refuses to have any contact with me for 7 years.
No.
So suggestions on maybe how to start that conversation.
Let me text my assistant because I got the time wrong. And I'm going to answer that question with the talking about text. I can't. Cancel. Schedule. I apologize for doing that, but I did have an appointment 5 minutes ago, but since we started late, I wanted to give you guys the time. But it's okay. There's a family I've worked with a lot, and we just had a 25-minute catch up, so I'm not leaving them in the lurch. So the question was about estrangement, right?
Right,
And
right.
if you think you know why your loved one is angry and upset with you, then if for example, it was, in my case, years of saying you have a mental illness or calling a mobile crisis team or an involuntary treatment, I would just preemptively apologize for that. Just like I did with my brother. When I called him up and I said, I'm sorry for all the times I told you you were mentally ill. I'm going to stop doing that. I never had to tell him he had a mental illness again, even though I offered him a long-acting injectable. And he said, why do you need it? Why do I need it? And I said, well, I don't want to get into that. I just would like you to do it. So apologize for what you think they're angry with you about. And if you feel comfortable, say, I'll try my best never to do it again. Say something like that. So that's the apology tool in the LEAP approach. I mean, it's really important to apologize for things like involuntary treatments or for arguments about whether or not the person has mental illness.
Thank you. We have a whole list, so I'm not sure we're going to be able to make all of them. They keep coming in, but you tell me when it's time to cut off.
Okay. Let's go for another 8 minutes until 1:30. Would that be okay?
That's perfectly great. Thank you so much.
Thank you.
My loved one's provider has never suggested a long-acting injectable. What's the best way to get the provider to agree to trying it?
That's frustrating for me because the best way, in my experience, is if you can talk to the provider, and if the provider says, "Oh, I don't have a HIPAA release, I can't talk to you," many of you may know this, but I think it's worth saying out loud again. Remind the provider, well, I know you can't talk to me, but you can listen and can I just share something with you. My son, my daughter has a long history of throwing away medication, of stopping the medication. Can you please think about a long-acting injectable? So if they're taking, there's a dozen oral medications that come in long-acting form. So look it up online. And if you know that your loved one's on one of those medications that's oral, that comes in long-acting, say, hey, could you offer the long-acting form? Because, she has this history of not taking the medication. So make sure that that provider knows that there's that history, because all they're doing then is a Band-Aid by writing a prescription for pills. It's not going to help.
Thank you. This one's a comment. I do appreciate so much the information around the language not being about denial, as though it's a conscious choice rather than a symptom.
Yeah.
So
thank you.
Let's see. What are your thoughts on letting individuals experience / suffer consequences of anosognosia versus rescuing them?
I do not believe in letting people hit rock bottom. It doesn't result in awareness. And people with the illnesses we've been talking about tonight are very vulnerable people. So my strongly held belief is if we can provide, shelter and food and some basic stability, we must do that. Other consequences, it's hard to know, given how broad the question is. But if you're thinking about letting the person suffer negative consequences because they'll learn they have mental illness, then you probably haven't really followed what I've been talking about tonight, because they're not going to learn no matter what the negative consequences are. Remember with my role play with Michelle, if she really was delusional and had anosognosia, she had lots of opportunities to learn. She was getting arrested, she was put on medical leave of absence, and she didn't learn. All the negative consequences didn't make a difference. So I don't believe in the negative consequences, and I believe very strongly we need to offer food and shelter, housing and basic necessities if we can.
Thank you. Hard one. How do you cross over from reflective listening to actually getting them to agree to help?
That's a great question. Well, let me start with just a statement again about why reflective listening is so powerful. The person feels heard and validated. Then they can start to collaborate with you. You can say, hey, can we agree on some things? I mean, I'll even take a piece of paper out and write it down. Can we agree that you want a job? Is that something you want? Can we agree you want to stay out of the hospital? Maybe find 2 or 3 things and then say, I'd like to work with you on that. Would you be willing to do that, staying out of the hospital? Well, what would it take? Well, you're not going to like my answer. I'm sorry, I think this, I could be wrong. There's my opinion, right? The opinion tool. I think when you have been on medication, you tend to stay out of the hospital. So I think it's worth a try, maybe just for 3 months, and you pick short periods of time, and let's see if that helps you. So that's just one quick example of how you'd go from empathic listening reflectively to problem solving with the person, finding, pointing out, hey, it seems like we agree on this thing. In my example, staying out of the hospital. I have an idea. Can I share it with you? LEAP is also about asking permission to give your opinion. And then you give your opinion. I'm sorry, I could be wrong, but I think if you take the medication, you'll stay out of the hospital. Well, do you think I'm ill? I'll answer the question if you want me to, but I think what's more important right now is what we're talking about, staying out of the hospital. Would that be all right if I answer that question later? There's the delay tactic. So the conversation is one where we're being humble and validating the person's experience, but we're giving our opinion, but in this very soft way.
Thank you. Great suggestions.
Thank you.
My family member is very sad about having to be on medication. Would an antidepressant help even though they are on an antipsychotic?
I'll do the I'm not a medical doctor disclaimer first, but then I'm going to answer the question anyway. Antidepressant may help a lot, but if your loved one has like a schizoaffective bipolar component, it can be tricky because you don't want to, but you can do it. So I would definitely talk to her doctor about it. But also cognitive behavioral therapy is proven to be as effective for depression as antidepressant medication. So if the doctor is not comfortable with antidepressant medication, if you can convince your loved one to see a therapist, and it's very problem solving oriented. It's really CBT, cognitive behavioral therapy, is very practical. It's not about going back and looking at your childhood and traumas you experienced.
Thank you.
So short answer is yes to medication, but if medication is not an option based on the treating doctor's opinion, then how about cognitive behavioral therapy?
My
I think we
28
have time for just one more.
One more.
Sorry.
Yep, that's I just took a look. My 28-year-old has had multiple concussions and is now showing signs of anosognosia, but will not accept help. He had a conspiracy theory issue beforehand. What can I do?
Go to our website and look at the videos on LEAP and just give it a try. One thing I often say to families, how long have you been trying to convince your loved one they need help? And if they tell me 6 months or 6 years, whatever, I then ask the question, has it worked? And if they say no, it hasn't worked, and I think the person asking this question might say no, trying to convince them it hasn't worked, then I remind them of Albert Einstein's definition of insanity. Doing the same thing over and over again, expecting a different result. So if you're in that place, maybe try something different. Go to the website, look at the free videos. There are free chapters at the NAMI National website. I donated 5 chapters from my book on LEAP, so you can start to learn LEAP by going to NAMI National and searching for the name of my book. Yeah, I'm Not Sick, I Don't Need Help book. I could say you could also buy the book, but I'm not here to sell books, so that's not it. There's free resources. There's free ways to get the information. Okay.
Great, thank you. And we
You're
do have
welcome.
one lucky person tonight that'll win one of your books for free. So I really do want to thank you. I thank you for being so persistent in trying to join us tonight. We know so many people were looking forward to it, and it was a great presentation.
Thank you very
informative.
much. My only regret is I couldn't be there in person with all of you. I would really love to have been there, but thank you for inviting me.
You're
Okay.
quite welcome. Have a good night.
Good night, guys.
Okay, so thank you all for hanging on and, helping us deal with these technical challenges. I want to make sure that you are aware that we have a virtual expo center that's available through the lobby. You can go in and check out. It's just like if you were in person at a conference and you go up to different resource tables. Tomorrow between 12 and 1, many of those booths will be staffed, so please make sure you check them out. There are files that you can download from tonight in the lobby. There's also a booth for that, as well as from this session. So I want to make sure you check all of that stuff out. Please keep in mind that there will be an evaluation that'll come at the end of tomorrow after the conference is over. We appreciate all of your feedback on this session and the conference as a whole. If you need a certificate of attendance after you fill out that evaluation, you will be able to download directly from there. Tonight was recorded, as all of our sessions will be, and hopefully by the end of the week, they will be posted in the lobby here. And then also we will be posting them on the NAMI New Hampshire YouTube channel. So tomorrow morning, please join us at 9 a.m. We have Susan Stearns, who you met earlier tonight, our Executive Director, and Lori Weaver, who's the Commissioner of the New Hampshire Department of Health and Human Services. And they're going to provide updates on the state of mental health here in New Hampshire. So we look forward to seeing you all tomorrow morning and throughout the day tomorrow, and have a great rest of your evening. Thank you.